Welcome to the Global Surgery Modifiers 54, 55, 58, 78, and 79 webinar. I'm Tom Ryan with Provider Ocean Education, and I'll be your presenter today. Today, I'm joined by Aline from my team, and she's going to be providing me with help in the chat, putting some different links in there, looking up different things, anything like that. Want to remind everybody that we did take some pre-submitted questions and y'all definitely sent in a bunch. So hopefully we'll get through all of them. If not, we'll send those out after the fact. All right. At any point, you can also add questions to the chat. By adding questions to the chat, we'll have those tracked. Again, if time permits, we will answer them and we'll make sure that we get through those. Today, our objective is to review the modifiers, and we want to talk just about the global surgery period. And what we're doing is trying to reduce your claim denials. If we can reduce those claim denials, hopefully that will help you out. So we've done a little bit of data to look at this and determine this is what needs to be done. We did have some really basic questions come in about the global surgery concept and the package. So I wanted to address those, which is what we'll do with the first part. Then we're going to define each modifier and look at the individual information. Then we'll talk a little bit about some resources that are on the WPS website that you might want to be aware of. The first set of questions, which was asked by a variety of you in a variety of different ways, is really, has anything changed? That's the summary of the question. So I want to address that before we leave that. No, this is a refresher course because we continue to see denials. So our goal is to look at the information. Many of you have used this information for years and nothing's really changed within it. So I want to make you guys well aware of that. We're not changing anything. We haven't changed anything, but we are continuing to see denials, and that's why we're putting this course on. So what is the global surgery comment? What is the global surgery period? Well, this was a few different pre-submitted questions that came in. So I put these slides together to hopefully give us that basic level of information. But I want to remind you, if I'm missing something or you need more, please put a comment in the chat. I don't want to leave anyone behind, but I also don't want to spend the whole time just going through the concept. So we'll talk a little bit about the concept and what the global surgery package is. So it is a single fee given for any surgery or procedure that this relates to. It involves a variety of factors which incorporate the preoperative care, intraoperative care, and postoperative care from one provider. This is called sometimes a bundle. We're going to bundle into the global surgery package. Though not the same thing as a bundle for like procedure to procedure edits, it is still one payment. The global surgery package, the purpose is to allow payment for a single surgical procedure. However, what happens if that surgical procedure isn't all done by the same surgeon or a member of the same group with the same specialty? Well, that's what we're here to talk about today, because that's what a lot of these modifiers will designate. When should I separate something out? Okay. So we're going to take this basic package and we want to say, oh, it's not part of the package, because that's what we're here to talk about today. One question that we did get is, how does Medicare define same physician? We get this all the time. It came in about 3 or 4 different questions. So basically, if you want to put this together, remember, Medicare doesn't say the same physician is one single person. Medicare says the same physician is the same specialty, and the same tax ID must be billed as the same physician and reimbursed as though they were a single physician. So that means that one of the questions that came in that was a great example was they had a provider who did a surgery and then had a patient who needed to go back in through a complication. How does that bill when that provider was on vacation, so a different surgeon did the actual complication? And they went back into the OR. And the answer is, it's still one physician. You're still paid for that in terms of Medicare. Now, keep in mind, I do understand that I'm going to use the term one physician. I do understand it's really 2 people. We get that. However, Medicare defines that as one physician. So there's our first question already answered. So again, oh, sorry, and I forgot to advance the slide here. Um, so remember that a provider under one group, they must accept, they're the same group, same specialty, then this provider accepts one payment as if they're a single physician. So when we look at it, what we're looking at is one, tax ID. Two, what we're looking at is um, a specialty under that. So if you say, I've got a surgeon, a general surgeon, and someone who is a cardiologist, it's not the same specialty, so therefore it wouldn't be applicable. The cardiologist may do some portions of the follow-up or other things, and we'll talk more about that. So we want to make sure everyone is aware of what one provider really is. The global surgery package does not apply everywhere. So someone asked me about this one. And so the settings that it really is going to focus on: one, the ambulatory surgery center; two, hospital inpatient and outpatient; intensive care or critical care units; and physicians' offices. Does this apply to something like a critical access hospital? And the answer is yes, it does. Critical access hospitals, their payment methodology is what makes them different, not the global surgery package. So if a patient has a physician even billing method 2 in a critical access hospital, the package concept still applies. So hopefully I answered that question about global surgery. FQHC could apply. Again, federally qualified healthcare centers, all of those different ones. Rural health clinics could also apply. And it's sometimes when we look at who's billing within it, okay, where's the surgeon employed at? Who did it and wasn't modified correctly to separate it? That doesn't change the payment methodology. That's just about getting the bill done correctly. So yes, it could apply in any of those situations. Remember that the ambulatory surgery center, based on the complexity of the surgery, it has to be safe for the patient to be in the ambulatory surgery center. Therefore, the place of service, it's not about the global surgery package or that concept. It's about the safety. So we were asked specifically about why some things are in an ambulatory surgery center or not. That's not about a global package. That's about whether or not it's safe. How many procedures can they do? How much is before the patient needs to be in a facility in case something else happens? The facility would be a hospital. So hopefully all of that does make sense. I'm trying to hit up all these questions at very high levels to make sure we have everything done there. So how does Medicare define global days, and what's meant by the different definitions? First, global days are defined on the Medicare Physician Fee Schedule Relative Value Files, RVFs. The Medicare Physician Fee Schedule, and we're going to show you that in a little while. It does say, hey, wait a minute, how many global days are there in each global period? And when it does do that, what it looks at is indicators. On the file itself, there are 3 distinct indicators that are used. 000 is the first one, and that just means 1 day. Well, why does that mean 1 day? It's the day of surgery, and no post-operative days apply. So the pre and post-operative work is all done the day of surgery. It could also be a minor procedure or a different type of procedure. So some people asked about, it's not technically a surgical procedure, but it has global days, 000. Why would that be? Well, that just means on the day of the procedure, everything is incorporated within it, okay? Also 10 means the day of the procedure, which would incorporate the preoperative care, and 10 days following, which is 11 total calendar days. So the surgery day plus 10 calendar days following. It's 11 days. Now the major surgeries fall into a 090, which is 92 days. That's the day before, the day of surgery, and 90 days following. Okay. So 92 days. If you want to use the link, and I'm just going to open it up this way, you can go to the physician relative value files right here, and it will open up the internet for you. Sorry, it's taking just a moment. It's going to take you to the CMS website, and then you can open up or choose a file. Here we are. If you don't want to do that and you want to navigate the CMS website, great. One of the things that I like is to use this physician fee schedule lookup tool right here. So if you want to go Medicare, you can always look down and be like, okay, where did I need to go? I'm not sure. And that's when you're going to scroll through the different options. Payment, fee schedules, physician fee schedule. And then here's the lookup tool. Way down on the bottom, down here is the relative value files. So this is going to give you a PDF document with everything versus this, which is just a simple lookup tool. Okay. We'll get into that a little bit more later on once we get a little bit more into explaining a couple of different things there. There are a couple other payment rules, and somebody did ask about one of these, so I thought, well, I'm going to put a slide in just so you're aware. Why? And this is where the question came in. What does that mean? What does contractor priced mean? It means that we are going to require documentation in order to even figure out the pricing for that procedure code. The pricing involves what is the procedure. These are commonly like a not otherwise classified code that are used as a default code. So that's where a contractor pricing comes in. Well, what are you doing with it? What's going on with this code? What are you using it to represent? And the documentation has to be sent in, and then we'll figure that information. We'll also provide you some information back. So that's where a YYY comes in. The ZZZ are for add-on codes as defines during the AMA. So it's a procedure code and it's an add-on code. So we say, hey, we don't actually give them their own global days. We actually expect you to go back to the primary code that you have to bill it with and follow the primary code. And the last one is XXX, and this just means, hey, there's no global surgery for that. There's no concept for that. All right. So let's stop for 1 second. I'm going to jump back to the website, and I really just want to take a quick look at the global surgery information that's available in the relative value files. The reason that I'm going to use this file is it's the bigger one. The other one is easier to read. Which is the lookup tool right here. And the lookup tool is way easier to read when you understand the main files. So if we download this piece of information right here, it'll be the most current file. And again, these are updated quarterly, which is why you may have an A, B, C, D kind of thing going on. It'll tell you when this was last updated, and then it'll also give us an effective date. Okay, so here's our effective and here's our update date, a little different. This one's not so far apart. And we're going to put this, let's just throw it on my desktop for a second here. And so you can see it's done in zip software. It's asking me, hey, what do you want to do with this? What I really want to do with it is go ahead and open the file, which is going to, again, depending on the software that you have, going to look like an extraction file. And this is the extraction from the zip. So this is all the stuff that's in here. We're going to look at these bottom two. So first of all, if you don't know how to read this bigger file, which is an Excel file, and I'll open it up and you can kind of see it. If you don't know how to read this, then this bottom one is what you're going to use to do that. And this is a PDF document. Now the Excel file is large, so it does take a bit of time to open. And what the Excel file actually does is contains all of these different codes that are interested. But what's important for us to know? Global days, that's what we talked about with the 000, the XXX, the 010. That's the column indicator for that. And then these little numbers. Now, so if we were to say, okay, in this column, I'm just going to use Control F, and I'm going to say I want something that says 090. Okay, then I've got 0.10, 0.71, and 0.19. These translate into the fee schedule. You take the full fee schedule amount. It's 10%, 71% for the surgical work, and 19% for the follow-up. So all of this is assigned by CMS. We don't assign any of this with the exception of a YYY. And the reason for that, again, it's nothing, you're like, wait, nothing's really assigned, and what do I do with that? That's the one that we price based on your documentation. So that's a little bit about the files, just again, using the bigger file for it, but you can definitely use the lookup. The lookup will have a little bit less information, might be a little bit more readable. So, all right. Before we move off of that, let me just stop 1 second. Aline, did we have any questions about just the basic information before we jump into the actual modifiers?
Thanks, Tom. Yeah, we did actually get a question, and this is back when you were talking about same provider. Leah asked, does taxonomy matter?
Oh, great question. And no, we don't use taxonomy with the definition. What we really do use is the, again, provider specialty that you designate, and then group practice, which is defined by tax ID. So when we look at it, you can have 4 or 5 MPIs within a group, just in case that's how you broke up, but the tax ID is what will drive. So what you enroll with Medicare as, we're going to take the provider enrollment specialty, and we're going to take that group practice information. Anything else?
That was the only question we've received so far.
Perfect. All right, well, let's get into a little bit more on the modifiers. Now, this is the biggest part of today. So what we want to do is we want to look at when can we document something to make it separately payable. So we want to remove it from the global package and we want it to be separately payable. That's our goal. And each modifier, of course, is a little different. So we'll start with modifier 54. Now, modifier 54 is only used by a surgeon. This modifier is used by the surgeon to indicate they are not completing the postoperative period. This means that it has to have a 010 or a 090 on that Excel sheet that I showed you. Because if it doesn't, the surgeon is still going to take if it has a 000, the surgeon's going to take responsibility on the day of care. So, yep, they're going to come in, they're going to go into, maybe they had anesthesia, so they're going to go into, post-surgery, they're going to come out of anesthesia, they're going to do all, that's still part of what's incorporated within it. So the surgeon is saying, wait, nope, I've got more days, but I'm not going to do the care. We do know that if this is in an ambulatory surgery center, this doesn't apply to you, and nor does it apply to an assistant surgeon. Well, that's because neither one of them have the responsibility for doing the follow-up care in the first place. That they don't have that. Again, the ambulatory surgery center, they're simply getting paid for what? The facility fee. The assistant is getting paid as extra help, extra assisting the surgeon. The surgeon is still taking primary responsibility. So if the assistant that surgeon is going to be the one who's going to take all of the primary responsibility for follow-up care, then the surgeon still needs to append a 54. Okay? So transfer of care for all of the postoperative care. Now, again, you can do surgery only, which means all of the remaining postoperative, you could do a portion. So you could say, I'm going to take the first 5 days, and then they're going to leave on a 90-day period, and then someone else is going to take the remaining 85 days. So it really just is dependent. What we will do is prorate that percentage amount and figure out the number per day, and then each one will be paid according to that. It is important that both claims, especially the surgeon's claim, contains the date of relinquish. The date of relinquish. This is in a narrative section, and this is just something to help us understand what's going on. So as we said earlier, remember you're paid a certain percentage for this. Well, how do we know how much of that percentage to take away if we don't have a date of relinquish? Okay. Along with the 54 goes the 55. What is the 55? Well, this modifier talks about postoperative management. So I'm doing the postoperative care, but I'm not doing the preoperative and the intraoperative care. That would be a 54-55. The surgeon would have a 54, possibly a 55. Now, again, it depends on if they're doing a portion of the postoperative care. So This is also used by any physician doing the postoperative care. So the surgeon only on 54, postoperative care by 55. Again, it is important to have the transfer date, but it is still billed with the surgical procedure. This is when that started. The whole date is done by that day on the surgery. Payment is based on, again, a percentage. It's a prorated amount. However, you do get to submit 1 unit, and that's not because you saw them 12 times or you saw them once. It's because of the way the percentages are broken up from the surgical. Everything is incorporated in that. I was asked if there are specific directions for Modifier 55 on cataract surgeries, and the answer is no, there's not specific directions. It really is about using the postoperative care. When did the surgeon relinquish the care date? If the surgeon said, I relinquished the care date the day of surgery, so I completed it, then you would use a 55 with relinquished care date on the surgeon claim, saying the day of surgery. The second claim that would come in would actually be the day after surgery with the surgical date and the relinquished date and all of that information, that transfer date information available. I'm not sure what exactly you were looking for with that. So yes. Okay. Oops. So examples, let's just do a couple examples right here first. First surgery and then partial follow-up care. So Dr. Johnson performs cataract surgery. I put this one in because of the question we had already received. On October 2nd, Dr. Johnson provides follow-up care through October 12th. So if we looked up a 66984, what do we find out about it? Well, let's do it. So first, we're going to look up 66984. We find out that if we read across, what is our global days? Well, we know there are 90 and that it's a 20% rate for those days, and we're going to prorate that. So, okay, we know that. Let's go ahead and close out of this. And so Dr. Johnson provides the follow-up care, but he does provide a portion of it. And then Dr. Johnson transfers to the ophthalmologist, Dr. Pierce, who does the follow-up care on October 13th. Okay, so then Dr. Pierce relinquishes the care on January 1st. That makes sense as we had an October 2nd date. So how does all of this work together? Well, the surgeon's claim first comes in and we do have the surgical date. Here you've got the 66984 with 54 and then the 66984 with 55. Each line quantity has 1. In item 19, you're going to see post-op dates. Assume care. Well, that makes sense. It's the day of surgery. They relinquished care on 10/12. Co-managing, which is Dr. Pierce. Okay, so yep, we still have the surgical. They didn't do anything here, but they did do this, right? This is the 55 line. They do get 1 quantity, and their claim says we assumed care on 10/13. They relinquished on 1/1. This is the end of the 90-day period. So it's important to make sure that all these dates are properly documented. Oops, sorry. So there's some errors that we're commonly seeing, and we thought we would just put this in for you. Incorrect claim date of service. Again, we still have to have that proper date of service, which is the date of the surgery, not the date that you relinquished or resumed care or anything like that, because without the date of the surgery, we can't tie it back. So that's one. No assumed or relinquished dates on the claims. How do we know how much to pay you? We have to take that and break it into a percentage or give you all of that 10%. But without those dates, we can't say, hey, you did 60 and you did 30, or you did 20 and you did, we don't know how to do that. No documentation transfer agreement in the medical record for the physician furnishing postoperative care. In other words, there's nothing coming from the surgeon saying, hey, take this patient's care over. What are we doing with it? Why are we transferring the care to you? You know, maybe they're too far away. Whatever the documentation is, it's not there. We don't know why you took that. You just did suddenly take it over. In that case, was the surgeon expecting to be there? Appropriate modifiers not used by the surgeon or the physician assuming postoperative care. Without those modifiers, we can't appropriately break that up. And so what that's going to do is could cause a couple of different issues. One, it can cause a claim to deny as duplicate. We've already got that surgery in for that date. Yes, it was paid to someone else, which is the surgeon, and then we expected the surgeon to do that care, but because they didn't put the 55 on there, then we don't know what they did for that portion, so we don't know which place to break it up at. So those are some really common errors that we're seeing. All right, that's 54 and 55. Let's move on. Oops, sorry. Move on. 58. Some people were looking for just a better understanding of 58. I want to start with a basic definition with 58. It is a staged or related procedure by the same physician during a postoperative period. For the same physician, again, CMS does explain that it is based on the definition of single provider. So it's not necessarily one person. So again, here we know what's going to happen. We understand that it's staged. We understand this might be a multiple. That's what we need to look at when we look at 58. One thing to keep in mind is if you're billing with a modifier 58, you're telling us you did additional work. So we will then start a new postoperative period. So if that procedure code has a new 90-day period, it'll start the 90 days over again. That is important because some people are trying to bill without it before. Okay. One thing to keep in mind when you're looking at modifier 58, we don't have a lot of issues with this one. We did put it in just based on some general information and a couple of questions. But at modifier 58, I will always tell you that your documentation needs to be clear. Start back. Was this something that you anticipated? Was this something that was staged or related? You knew it was going to happen, or if you didn't know it was going to happen, it's still related to it. Okay. Now, again, the documentation becomes a key component. Each case, of course, requires surgical documentation. Without that, we don't have anything. But then we also require an evaluation to demonstrate the intent of the treatment. What else needed to be done? It's necessary to explain that no other modifier would fit the situation. Because remember, the first thing CMS says is, hey, you need to use the modifier that best fits. So 58 sometimes is confused with 78. We're going to talk more about that. They're both surgical modifiers for repeat procedures. However, there is a distinct difference. We'll talk more about 78 because it's an unplanned complication versus a planned or staged. Okay. So again, that's where the documentation is so key, especially in this one, because is it unplanned? Was it planned? We do know they're both all related, and you want to make sure you're hitting the right one in this case. Don't use an ambulatory surgery center. Again, 58 should not be used by assistant at surgery. Procedure codes with 000 and XXX as global days. Can't return if there's no global days. Now the follow-up carrier member has to be there, and that's where you're looking at. Unrelated procedures during a postoperative period should not use 58. One of the key things with this is it has to be related. Reporting the treatment of a complication from the original surgery requiring a return to the operating room. Remember, it's a complication. Did you anticipate that complication? If you didn't, then don't use this one. The complication again would go 78, but it's a different modifier. We'll talk more about that. Okay. So could someone come in and say, I did a procedure, it was done in the emergency room, and I'm transferring care after this back to the primary care? And the answer is yes. Yes, you can do that. Okay. So you would not typically use a 58 in the emergency room. I just want to make that clear. Someone asked me about this. You're not returning back to the emergency room, right? Now, if they came in, yes, they could do an unrelated, but that's usually used with a 78. So does that, hopefully that makes sense to everybody when you look at those two. Okay. So modifier 78 is next. And again, we've kind of alluded to this or talked about this. I want you guys to keep this keyword right here in mind. Unplanned return to the OR by the same physician or qualified professional following initial procedure for related during the postoperative period. CMS does use this differently than the AMA. CMS instructs us to use this as the treatment of a complication, okay, or a return to the OR, okay, not or. As they return to the OR, it's only used for return of a complication. So not like 58, not like 58. 78, 58 are different. So that does mean that someone could come in and say, hey, by the way, the surgeon came in and did the original procedure. They billed a 54. They did build a 55 with a relinquished date on the day of surgery. Then another physician came in and billed a 55. Then the patient came to the ER and now they're going to bill a 78 because, right, all of that is possible. That's a scenario question that we got. I didn't have a lot of detail with that scenario style question, but it is possible. Okay. So when we look at that, someone asked me, is there an area that we can reference to for the CMS use of this as a complication? And it is in the Medicare Claims Processing Manual. It is in Chapter 12. Okay. You want to make sure you're looking at Chapter 12. Check out Section 40.1 for A, 40.2, A5, 6, and 40.4. So I'm going to go ahead and put that into the chat. What I'm going to ask Aline to do is, oh, nope, Aline's got that in the chat for you already. I don't have to do anything. Nice. So take a look at that if you're interested. It's not in one location. It's in a variety of places, and it all plays together. So check out the proper use based on that, and that's where you're going to get that it is for reuse for return. Now, it was mentioned in multiple questions, hey, this is used different than the that's okay. We have to follow what CMS tells us to do, and that's where this comes from. So again, the purpose is a related procedure during a post-operative period. Now remember, it has to have a post-operative period. If it's got 000, that means it's the day of surgery. Okay, you are required to return to the OR. So if you're not returning to the OR, this wouldn't be the situation. Now, again, an OR is defined as a lot of different things, and you want to make sure you meet those definitions. You're going to treat the patient's complication resulting from the original surgery. When the procedure code used to describe a service for the treatment of the complication is the same as the procedure code used in the original procedure or the original surgery. Keep in mind, a 78 will also begin a new global period. So if it has a 90-day global period, you go in at day 60, and then you have another global period that will begin again for 90 days. Okay, so this one, lots of stuff going back and forth with it. So we were specifically asked, is there anything you can give us advice as an OR? Well, sure, start with the operating room. Of course, that's going to work. It could be a cardiac catheterization suite. There's laser suites. There's endoscopy suites. It typically, or I shouldn't say typically, it does not include the patient's room in a hospital or minor treatment room, a recovery room, or an intensive care unit. It's very different. Okay, so we want to make sure we're using this correctly. Let's talk a little bit just about a couple of errors that we're seeing with this. You're reporting this modifier on something that has 000. Well, that's going to cause an error because we're like, why did you return during the same day? Why isn't that all just built into the procedure? Okay, don't do that. You're putting a 78, but it wasn't related to the original procedure, or it's a completely different code. It's not the same thing. Also in an ambulatory surgery center, because remember, they're not staying there. There's no complication. They could report to an ER. That does happen. And then through the ER, they're sent back to the OR. That does happen. So it's just a difference. So please make sure you take the time to review the global days. Also, we want to make sure that when you review the CPT terminology, How is it described? That becomes key. Does this play into certain things? If not, we're good. All right, we were asked a couple of questions about modifier 79. The most generic one was just, how do I use modifier 79? Well, we want to make sure that you're using it appropriately with an unrelated procedure that was performed by the same physician during a postoperative period. So it's not a complication to the original surgery. That's what we already know. You're not returning to the OR for the original surgery. It has to be unrelated. Unrelated. The appropriate use when reporting identical procedures performed on the same day by the same physician, but are not the same service. What does that mean? How about not the same anatomical site? Maybe I did a right and a left. Maybe I did surgery on 3 fingers, different anatomical sites. Keep in mind, 79 will also begin a new postoperative period for the care for that service. This is an informational modifier, which means that it should fall after one of the payment modifiers, and I'm going to show you that in just a couple of slides because we did have a bunch of questions come in about making sure things are put correctly for the system. And the system that they're talking about was the multi-carrier system. And we'll talk more about that in just a few moments. Okay. You always want to make sure that your documentation supports the modifier. I'm not sure what is happening, but sometimes we're getting claims in, and when we request the documentation, that unrelated procedure is not supported with 79. And that unrelated procedure is one of the key components that we look for. So we want to make sure that when we document, why is it unrelated? Why is it unrelated? Whatever that happens to be. Again, there's a variety of different factors that could figure into that. What should we not use this for? Well, as I keep saying, related procedures. Surgical procedures with an XXX indicator. So that means the global days are indicated with an XXX. So it has to be a 10, 010, or a 90, 090. Surgical procedures outside the global period. So if it's on day 15 and it was a 010, that's not within the postoperative period to start with. Therefore, anything related to that would be outside or unrelated, which is in this case what we're talking about. When a different physician performs the operation, different group, different specialty, any of those types of principles will apply to this one. Also, we don't use these for ASCs. One of the things that has happened frequently, again, is the related procedures. Let's see. So there's a bunch of different factors happening with this one. And the one thing that is key when you look at it, please go back and review those global days. You're going to hear me say that a lot. One key piece of information is actually documentation. So when you go to document, that's where these key takeaways come in on the next slide. Because the key takeaways that you're going to want to document, one, why is it staged or unstaged? Which modifier would that append to? 58. Was it related or unrelated, so that you can get the appropriate modifier there? Your documentation is what is key to splitting everything within that. Documentation tips start with, can you easily identify what's going to make it separate, what's going to make it related or unrelated, all of those types of things, because it just depends on which one you're looking for. If you cannot, then can you incorporate a statement that will help someone who's reviewing it find that information? Because sometimes it's written in such a way that it makes it a little unclear, and you know your providers. We don't necessarily know your providers. Okay. Of course, there's a little bit of billing information that we do want to go through. Oops, sorry, I didn't move to this slide. Couple of things to keep in mind. The modifier fact sheets are great. Aline's been posting links to those. I want to show you where to locate these, because these modifier fact sheets are based on what our system actually looks at when we process the claim. So if you come to the WPS website, and this is wpsgha.com, and you make sure that you're in the Part B. So you can either be in Indiana or Michigan, which is J8. You can be in Iowa, Kansas, Missouri, or Nebraska, which is J5. Part A processes differently. It's a different system. So the multi-carrier system, which is built on a 1500 or an 837P line of business for CMS, will always be labeled Part B. From there, you can go to topic centers. And inside topic centers, you can go to claims. Once you're in claims, you scroll down. You can open this one item for modifiers, and that's just referring to the landing page, which is this page right here. For other people who don't want to go that far, I'm going to jump back here. You can simply go to quick links, scroll down, select the word modifiers. So many people are looking for this that we actually have a link to it. What we've done there is giving you different pieces of coding and billing information, and you can see just a lot of fact sheets, but I want to stop at the first two right up here on the top. When you are billing to MCS on a 1500 claim form or an 837P, pricing modifiers must go first, followed by informational modifiers. Pricing first, informational second. So if we look that up, we'll find out that of this list, which ones have to go first? Well, that means that we should be appending the modifiers 54, 55, and 78 first, and then we're going to append 58 and 79 in second position if you have to use them. I'm not saying all of that. We actually do have an asterisk that you'll want to note, and this asterisk does say, hey, do you have other modifiers that may need to be appended? Okay, they're not limited to the first position. That's true, because if there was something else that needed to go in front of it, you may need to put something else in front of it. Okay, and then if multiple pricing, okay, so we want to make sure we're aware that these are the modifiers that go before informational only modifiers. Now, this is something that our system needs just to help it get through the process. So I was asked for a processing tip. There is your first one. So we want to make sure that that gets done correctly to make sure it processes right. I mean, and to actually get it through the system a little bit easier. All right. So along with those, we also do have individual modifier fact sheets, and you can scroll down and search for any of these. There would be, what are you looking for, and help me understand. So let's say that we're looking for modifier 79. You can search through this list until you find it. You could also just I like to do Control F. This is just my thing. And I can put 79 and it'll find it on there really fast. Or 79. You can, if you're looking for information on modifier 79 and you want to find this without having to navigate to this page, absolutely use our search feature. What we'll do then is look at all the different information that we have post, appropriate, inappropriate. If there's other things you need to be aware of, you may find tips, etc. on there. There's 78. Talks a little bit more about it, a little bit more about some facts and things like that. So basically everything I gave to you today, we also do have available on our website. It is in these modifier fact sheets. Again, kind of making sure you're hitting what you need there. Global surgery coding and billing guidelines. This is just a tip sheet that's going to be available on our website. Oops, sorry. And this is going to be the claims section. So let's take a look at that next. Again, we're just going to back up a little bit here because we're right in the same section. We're going to go topic center, claims, make sure we're in one of the Part B areas. We're going to filter for global. There you go. Pops it right up. Take a look at that if you want. Explain everything we want to, but it's going to give you the links. the information that you need to move around. So this is really nice information. It's just an easier way of finding it if you're not familiar with using the CMS website. Some people really prefer this method. It really is up to you. Okay. Another item that someone did specifically ask about is on the next slide, and I'm not going to leave here, but they asked about the universal calculator, which is this calculator up here. And I think they're using the word universal as it comes if you go into the tools and you go into date calculators, it's called the universal calculator because you have to select the type of date. But it is actually a fairly easy, it's only for 90-day global periods, and it says if I did a surgery today with a 90-day global period, the global period ends on May 18th. It's totally what you're going to get out of it. I'm not sure what other questions you had on that, so if you do have a couple more questions, if you could really help me, that'd be great. Oh, I forgot to move my slides, sorry. The next one is some information that is available on overpayments. This is a new slide that's not there. And what we want to remind everybody is that overpayments do happen related to the global surgery package. As a matter of fact, when certain claims come in, the surgeon can bill for certain things. It's going to override and cause other things, which would be possibly your claim, to be denied because it is part of a global package. So what happens? You might get an overpayment. So a couple things to keep in mind. Overpayments do need to be returned to us. The best way to do that is on our SNAP. So if we're looking at our website, this is SNAP right here, the Secure Net Access Portal. Tool that's available to you. If you want to learn more about overpayments, go ahead and read the portal user manual. You're looking for anything related to overpayments. I'm just going to scroll down to transactions. Here's transactions. And as I go through overpayment claim adjustments, OCAs, this is what we're looking for. And you really do want to complete this. This is the best way to do it. We do have some forms that you can use. They're available on the website as well, and they're in the all forms section or in the overpayments area. It just depends on which one you want. When you go to that, please make sure that you're selecting the correct jurisdiction across the top. And then on the form, you also need to make sure that those areas are filled out correctly. So that's why we always recommend using the portal with that. That's a new slide. It wasn't in your original slide deck. So if you say, hey, I don't have this one, that's okay. We did talk about both of these. The chapter 12, Aline gave you that link and why it's important. So the sections are there, 40.1A, 40.2.A5. Take a look at that. And then the Medicare physician fee schedule. Which brings us to the question and answer area. Now I'll get through as many as I can. If you do have questions in the chat, we'll get to those in just a moment. So the first question, how do these modifiers relate to critical care codes since the FT is used? And an example of documentation would be great. Well, the example of documentation is not something that we're actually reviewing for right now, so I don't have any sample documentations at this time. Now, this doesn't mean that just because WPS isn't reviewing, that another contractor can't review. We know that that happens. What other contractors could review? The recovery audit contractor, they can focus on certain things. The CERT comprehensive error rate testing contractor, can all review for that. Okay. One of the FT modifier was the first part, and it is for critical care codes. It is not for surgical codes. So you use 79 for surgical codes, you use FT for critical care codes. They're different codes. So I'm not really sure how or what you're looking for with that one. The next one was more of a generalized comment, and I don't really have anything to add, but why insurances don't like modifier 79? We do accept it. We do use it. What other insurances do, we can't comment on. Next question is, what happens if another provider also bills a procedure? This one is interesting because this is where we talked about the automated returns, which was related to that overpayment slide, which is why we actually put that slide into this deck. So let's say that a surgeon comes in and bills a procedure, and then another provider bills for post-operative care with the correct modifier, but the surgeon didn't put any post-operative care. Or I'm sorry, it goes in the opposite order. Let's say that the original claim came in and it's billed with post-operative care. only post-operative care. So the surgeon's claim comes in without a modifier to say they transferred care at all. We can actually, the system can actually instruct it to take some money back from the person who billed it first, but really the second portion, because remember the package says it has to be billed entirely to this by the surgeon if possible. So that's really what happens, and that's really one of the problems that we're seeing. And what's actually going on there is they're actually taking the money back. Well, really, it's just because the modifiers aren't billed correctly, which then lets someone to ask if they could appeal this decision. You can appeal any overpayment. So an overpayment decision is not a claim decision. It's when you get the letter requesting money back, and you can appeal that with additional information to say, hey, we did this. We may be able to then change that so that the surgeon gets a portion of an overpayment. So the prorating can happen at that point as well. Is it true that modifier 54 doesn't apply to ED? I'm going to assume you mean like emergency room department, not that you mean erectile dysfunction. So, you know, keep in mind, and the reason that I bring that up in that kind of funny manner is we want to make sure that we're getting the right thing. And so when you use acronyms that are common but have more than one meaning, we want to make sure we're addressing the right thing. If I'm not talking about the emergency room department and that was not what you meant in this case, please let me know in the chat. So the modifier 54 would be something that could be done in an emergency department. It's really based on the procedure code. It's not excluded from the emergency department. And so if you think about it and they come in and they're having something done in an emergency department, we really want to make sure that that is a procedure that has, one, a postoperative period, two, the care is done in that manner. And yes, the person working in the emergency department can automatically relinquish it and say, go see your primary. Here's the information needed. So hopefully all of that does make sense when we talk about that. The next one I'm going to say to you, please contact customer service, but it says, why does modifier 79 cause a processing issue for Medicare? Modifier 79 doesn't cause processing issues from what we can tell. We don't have any more significant denials for that than anything else. So if you're getting everything denied, I'm not sure. Now, someone did ask very specifically on a second eye, they're having issues. Okay, that one could be something where is the more appropriate modifier an RT and LT? Anatomical modifiers, I did the right eye and the left eye, because CMS says you have to use the more specific modifier than, hey, I just took them back in for a 79. So I would really consider you to look at the modifiers. If you continue to have problems, though, do contact customer service with your claim number and ask the questions. What is the primary care provider's role in global surgery period, if any? The primary care provider really doesn't have a big or significant role other than when the care is transferred to them. That's a 55. So they could be doing the post-operative care, yes. Someone did ask specifically about a 56, and Medicare does recognize that modifier, though we rarely see it. For those of you that don't know, it would be on a 090, and it's when a surgeon has someone else do the preoperative workup. Typically not done. It's typically being done the day of surgery with them. So it's really just not a modifier we see used very much. How to appropriately use 78 and 79? I don't know what you're looking for that. They were asking specifically about ophthalmology procedures. And again, we talked a little bit about that. So can you discuss whether modifiers are needed if surgeries are related, but the surgeons are different, but still in the same group? And we did that when we talked about what Medicare considers one surgeon. So just because the surgeons are different, can you tell me, are their specialties different? Because it can definitely affect. So if you have someone who is a surgical general surgeon versus someone who is a cardiologist who does surgery, who has a entirely different specialty, that's definitely something we want to look at. And that will affect how it works. So that's what we're looking at. Again, same group, same specialty, same provider, same group, different specialty, different provider. So you may not need to even put these modifiers on there depending on what's going on. Now that's not always true. If there's a complication from the previous surgery or something where it has to be done differently, then you may need that. I can't really advise you on that. I do have just a couple of minutes before I close out here. Aline, do we have any questions in the chat? Okay, I'm not hearing Aline. Let me just take a quick look. All right, if I miss any questions in the chat, we'll get back to you on those, but I do think I got everything. Let's go ahead and close out. So we're going to send you again a link to the survey. This will come out in the email that does the follow-up. It will also come out when you close this, you're going to get a little pop-up box. I want to make you aware the pop-up box is not malicious. It's not malware. It's not anything like that. Literally is what we're doing here. The information that you'll need for that is again provided right on the slide. We actually gave you a picture of it. So please make sure that you are aware of what that picture will look like. Want to remind you that if you do happen to listen to this as an encore, you want to go back and review any of the information that we gave, you can do that. We'll get that encore posted as quickly as possible. That'll be available on YouTube, and then it will also be available on our website. So again, if you see the lower picture in Encores or on YouTube, that just is a survey again available to you in another way. I want to make sure you get that one done. Want to remind you that if you have questions after this event, you are allowed to send those questions to us for 7 days. We will take any follow-up questions for 7 days. That must be done to wps.gha.education@wpsic.com. Please include global surgery modifiers, global surgery modifier webinar, something like that in the subject line. For those of you that dialed in and you need a certificate, you can email us there as well. We'll get you that certificate. Here's the catch. In the body of it, please put, I need a certificate. I attended the whole thing. You need to give us a 10-digit phone number. We will have to verify that 10-digit phone number. Okay. Again, as I said, I'll respond back in email to anything that I have, and I'll email the individuals out. So we want to thank you for listening. We hope that you will join us in the future. Please complete our survey if you have the opportunity to do that. We would really love to hear from you. On behalf of myself, Aline, and all of Provider Ultra Education, thanks for participating. We look forward to your survey comments, and we hope that you'll join us again in the future. You may now disconnect.